Oh, great. Hi. So thank you and welcome back to the Hammersmith for the second case from here today. So we have another PFO closure case. I'd like just to introduce everyone who wasn't there for the first case to the lab team. So Bushra Rana on transesophageal echo, Esther Anitsitis, the entire lab team, and Arif, our senior fellow. So Arif, can you please just run through our case?
Yeah, thank you. Good morning, everybody. So the patient that we have for you today, she is a 50-year-old lady. Yep. Are you seeing the slides coming through on your end?
Yeah.
Okay, great. So she's a 50-year-old lady who had an acute basilar artery stroke last year, required treatment with both thrombolysis and also a percutaneous endovascular approach. The MRI confirmed actually, again, multi-territory infarct over here, but she made a good functional recovery with a bit of mild residual upper and lower limb weakness. Past medical history, migraines, hypercholesterolemia, but well-controlled LDL on atorvastatin 40, and an ex-smoker stopped 2 years ago. Medications, as you can see, clopidogrel, statin, and lansoprazole. Yep. So she had a comprehensive investigation as part of the stroke workup. Initially, the cholesterol was high, but then controlled on the atorvastatin, normal coagulation screen, rheumatological screen, sinus rhythm on prolonged monitoring, normal CT angio, and echo showing a structurally normal heart. We did see the PFO tunnel on investigation. We saw it was a little aneurysmal on the TOE, and on the right-hand panel, you can see what looks like some bubbles going across upon release of the Valsalva. So then in terms of characterizing this PFO in the context of our discussions today, the rope score comes out as 8, and on the Pascal scoring, probable PFO-related stroke. So the session and the plan for today?
Okay, so the provisional plan here is for us to possibly implant a cocoon PFO occluder, which is very much like an Amplatzer device. It has a coating, and hopefully we'll be able to demonstrate that for you. But I think the first thing is if we go straight to live TOE with Bushra, because the anatomy here is actually very interesting indeed. And I think it'd be useful just to get some opinions from the panel and from Bushra to see what the best strategy would be.
Okay, so can you see the echo screen?
We can.
Lovely. So this image is just playing. Can you see that I'm scrolling down pushing down from 0, high, and all the way down at the transverse plane, straight down to the inferior septum. And you can see that the septum looks aneurysmal. You can see that there is a PFO opening, but it looks like potentially there's quite a lot of overlap. So just doing our checks, where now it's roughly the aortic rim area, and you can see the PFO is directed towards the aorta there. But what's also interesting is there's a slight lip of tissue here, which is very interesting, yet the opening seems relatively tethered. So moving along to your 90-degree view. So again, we can see a bit of the opening of the PFO, but you can see there's quite a lot of breathing movement here, which is actually causing the image to move quite a bit. But you can see the opening beautifully here towards the SVC now, clearly. But I'm very interested in what's going on down here and the opening that I'm seeing here, because again, at the LA side, it seems relatively tethered. And then just to show you that in this view, it just demonstrates actually how aneurysmal the fossa ovalis is. And if we now move to the 3D imaging, so this is interesting. So just to get your landmarks, you've got the mitral valve here. This is your LA view, so roughly 8, 9 o'clock. You've got this superior right vein coming in here. You've got the inferior right vein coming in here. And so in front of us is the atrial septum. This is all primum septum in front of us. And you can see how the septum is bouncing towards us intermittently. And you can see the opening of the PFO. And I'm just going to see if I can stop it at the right place. Kind of there. So can you see if I'm going to move this image around? It looks like the opening is here. But what's also interesting, and I'm not sure, is whether there's something else going on here and whether this is a lip of tissue that is sealing in between, so that you almost have two orifices. I don't think there is, but I'm not 100% sure looking at this imaging. What's important to note is if you look at the opening of the PFO, it's quite small. It's about I measured 6, 7 millimeters. And in terms of a potential tunnel, it suggests that there isn't much of a tunnel just looking at this 3D directly. I'm just going to find the right measurement. So if we assume the fossa is here at the top, then this is the length as a rough guide. But obviously, I'm just going to show you a little bit more in a second. Maybe not too much of a tunnel. But what is more complicated now is if I look at the other side, this is the right atrial view. I'm going to turn the gains down a little bit and let this image play. So again, just to get landmarks, here you've got the SVC coming in at the top here at the back. You have all of this is the IVC orifice, and also inferior but anterior is your coronary sinus. You can see your aortic root, ascending aorta coming in here. There's the root. You can see the valve cusp. This is the non-coronary cusp. A bit of the left is coming in at the back. And then now if we turn our attention to the atrial septum, now we have our landmarks. Well, let's have a look. So this is all atrial septum in front of us. Here very nicely demarcates the fossa ovalis, and you can see all of this thickened septum secundum tissue all the way around, which is quite prominent. The aorta is also quite prominent. It's a big structure in this atrial septum. And you can see this ridge coming up and attaching to the top here. And we saw that on the 0 degree view, which I will go back and show you in a second if we want to. But what's interesting is there's a fold of tissue here, which is that lip of tissue that I showed you on 2D. And if I look up from the bottom on the IVC into the PFO, this is what it looks like. So I've just cut into that same picture. So there, just to get your landmarks, there's that picture again. There's the top of the fossa. There's that lip of tissue. If we roll it down and have a look, can you see how much that PFO is opening? Oh, let me stop it at the right moment.
That looks great, Bushra. I'm going to ask Rita a quick question.
So,
you know, when
and you can see, look at this opening.
This
is the right
atrial side here. What are you thinking about devices? Do you want a device that's big? Do you want a device that's going to be small? What are you worried about with that? I mean, Bushra's got beautiful images here.
Yeah, beautiful image. I think there's a clear aneurysm. I think the choice of device will be interesting here. I'm not sure that I will choose a PFO occluder in a case like this. I will certainly balloon size and potentially select an ASD occluder in a case like this, but I would be happy to see the opinion of other.
Hands up everyone who will balloon size this.
Got a bit more to add in terms of the imaging.
Yeah, nearly everybody.
So Bushra, the poll in the majority room is almost all the hands went up for balloon sizing. But I know you're going to teach us 3D TEE here and how you're sizing it.
DDD, before we do that, because we don't know what we don't know, hands up who would not balloon size. Okay, so there is a good minority that won't balloon size.
Wait, did you raise your hands all again to the same people? It looks like they all raised their hands twice.
Can anyone explain why they wouldn't balloon size, given the uncertainty of the anatomy? Go for it.
A couple of comments. I'm going to speak about the TE perspective here in a little bit, but I would say the images are of such quality that even if we add a little color and we use multiplanar, we should be accurately sizing from the largest to the smallest. And then on top of it, I'm not an interventional cardiologist, so I'm not ballooning anyways. So I think the 3D color with the 3D information should be providing enough fiduciary information to really know what we're looking at.
Thank you, Burkhard. What about you, John? John Carroll, the master at PFOs. I saw your hand saying that you would not balloon size. Please.
I would just cross the PFO and with a stiff wire, hold the primum open and then see what I see. I don't see anything that really bothers me from using a routine PFO closure device so far.
Okay, Neil, are you planning to balloon size?
There's one more comment.
Very quick question for who
one more image to show, which I think
opt for not balloon sizing. Can you tell us very quickly what size of device would you put for who will not balloon size?
Bushra, the question is, if we're not balloon sizing, what size device would you recommend?
Okay, so can I just show you a little bit more of because I haven't shown you the multiplane reconstruction, which I think is really informative here. I mean, we've described the anatomy. Just to show you, I've aligned myself up with a PFO, long axis and short axis. Long axis is the green box, and the short axis is going to be, the long axis is the red box, the short axis is the red box. And so you can see the image playing there, can you?
Yes.
And I'm just going to do the measurements, just show you how we assess this anatomy of this defect. So I've frozen it where the PFO is opening. You can see it in the bottom right corner where the PFO is there. Assuming we're not missing anything here, because I'm not sure entirely, which is why I'm looking forward to the wire coming in, and I'll explain why I think there should be balloon interrogation here. What's interesting is just at the top of the PFO.
So once you're finished, I have got a wire across now.
Yeah.
So if you go live, then you can show that.
So 7 millimeters is the opening here. As we walk ourselves down this hole, it gets a bit wider to 11, and then as we come to the bottom, so the RA opening, it's now actually 18 millimeters, and there may be a bit of a tunnel which we measured about 7-8 millimeters. So I think this is complicated, and normally I wouldn't balloon size in most PFOs when you have this anatomy, 3D anatomy like this, and you can see everything. But in this case, I don't actually know how it's going to behave, and I'm worried we've got a small LA opening and then a wide RA opening. We've got an aorta, we've got a ridge, we've got limited space. So in this case, I suspect that we will go for an ASD device because we're going to plug the gap. But it all depends on how the wire behaves, and it also depends on the balloon.
Okay, super helpful. Is that a stiff wire, Neil?
No, it's just a standard J wire, not stiff.
Okay. Comment from Dave Northridge. He couldn't quite get up to the microphone.
Never a truer word spoken. So I don't understand the chat about using an ASD case, occluder in this case, or any other PFO for that matter. As Bushra showed you nicely, the opening on the right side here is much bigger, and I want a big disc on the right and a small disc on the left. In fact, I always want a big disc on the right and a small disc on the left. And turning it around so you've got a big disc on the left and a small disc on the right does not make any sense at all.
Okay. Would you be worried about the prominent tissue on the right side?
Well, you've got to get a seal on one side or the other. So, I mean, basically, PFO devices come in 3 sizes, right? There's a big one, a small one, and a medium one, and you're going to use the medium one. So I wouldn't be fiddling about
or the big one. Why didn't you use the stiff wire there, Neil?
I think the only other measurement we haven't seen actually that would be helpful, Bushra, would be just to measure the whole septum. But I mean, a big one would be a 30 millimeter disc on the right, really. I'm not sure there's room in this, but we haven't seen that measurement.
There's different sizes of big one, Dave.
Well, you can go 35, yeah, but I mean, I'm not sure there's room. It doesn't look to be that big.
So, Dave, on your point on the side of the disc, so there's the atrial septum, 36 millimeters, but the point about the space, if I can just show you the 3D again, our worry here is that actually, if you look, the wire's gone through. This is a RA view. We've got this ridge coming up, and sorry, let me just orientate this 2 seconds, just a bit better. So we've got the ridge coming up here at the bottom there, and we've got the aorta here, and this is the space you have. So you've got 18 millimeters opening. And if I just freeze that, our concern is that you don't have much space here for the disc to sit flush on the septum. And if it's too big, your disc, because obviously you need a bigger one, you're saying, to cover the big RA opening, actually you'll sit on the aorta and on this ridge, and then it'll display the PFO open. So that's why I'm worried that this actually is the strategy. I mean, depending how the balloon looks, the strategy is better to plug rather than close the flap, plug the hole rather than close the flap.
Okay, so Neil is itching to inflate a balloon, I think.
So just a quick...
Is that right?
Yeah.
Go and inflate the balloon, Neil.
Balloon's going up. Yep. A quick poll to the room. How many of you have actually seen a cocoon device or actually implanted a cocoon device yet? Okay, so we are here to learn a lot from you guys, Neil and Bushra. Only 4 hands went up that have ever seen the cocoon device or have implanted it. So please guide us in your selection.
Someone think that the balloon provides information not only for the sizing but also for the pre-shortening and to decide the different devices, because the balloon provides information regarding the sizing but also regarding the anatomy and the change of the anatomy during the inflation.
Agree.
So I'm definitely a balloon sizer, and I think if you look at that balloon inflation, this rather complicated looking PFO, my guess, is becoming simpler and simpler as we stare at that. And I think that's where I think balloon sizing really helps.
Dr. Yoon, how do you in your practice with balloon sizing apply it?
This kind of case, the morphology, I would do balloon, but then the interrogation we measure and then we will decide.
So on the basis of that balloon appearance on there, what device are people now leaning toward?
Question is, what size is the balloon?
It'll be a 10mm PFO.
So those markers are, the little markers are 5. So the top to the bottom marker is a 10mm distance. So that's about 11 probably, 11 millimeters.
I'm getting between 10 and 12 on echo.
So the waist is 11 and on echo it's 12. So
Iqbal, you've had a lot of experience with the Cocoon device. Would you consider equally discs on this?
Shall I bring that balloon down?
So I think anything will fit here. I take Dave's point on leaving less metal behind on the left-hand side. But actually, if whatever device is available, this is now becoming, I think, quite a vanilla case, but not too big on the right atrial disc, as Bushra says. It'll have to be at least 18mm because it's an 18mm hole, so it's going to have to be bigger than 18, so 25 on the right atrial disc, and whatever happens on the left atrial disc, I think won't matter that much.
Hey, Bushra, how does a mitral valve look? Is there any MR on this patient? Yeah. Because one of the things at our institution that we worry about is we can close any PFO and we can close any ASD, but which one can we burn across in 5 years if they have mitral valve disease?
Yeah, the mitral valve is normal here, just to show you a picture, but...
Darn.
Bushra, what size did you get on balloon?
I got 11, 12 millimeters, yeah.
Okay, so 25.
So the options are a 25-18 or a 25-25.
You don't need the bigger size on the left atrial side, though, do you?
No. So the standard device is a 25-18 for a cocoon. I'm told in the lab that that device isn't available. So the options are for cocoon or a 25-25, or we switch to an alternate vendor. I think we should maybe try the 25-25, see what that looks like. If it doesn't look good, we can take that out and then switch. I think would be probably the most appropriate.
Neil, we have a question for you from the panel here. Marcus, go.
Yeah. The question was why did you choose the Cocoon device?
So it's a very soft device. I think we've had a relatively large amount of experience in the last 12 months of Cocoon. I have to say that I think for the majority of defects, I think all of the devices are very good. I think anecdotally we found that it's a nice soft device that conforms very well. It's very nice and deliverable, and actually patients do, well, just anecdotally, people that come back relatively soon after their closure do seem to have negative bubble echoes. They seem to close pretty early on. I mean, I don't know what Iqbal's things from his own patient cohort.
So I've got to say that our closure rate for most of our PFOs is pretty high, and we do always check with the bubble echo. I'm certainly not minded to say it's cured because we put a device in. It's cured if the shunt is gone. And it does seem, I think it's a Me Too device, but it does have a coating. So if you're one of those believers that nickel allergy on the skin has anything to do with anything, you could use this device because it's coated. I personally don't believe it. I don't think skin nickel allergy has anything to do with what happens inside the body, and I don't believe it, so I don't test for it. But some patients go that way and say it's a coated device, therefore there's less risk of an allergy.
Yeah, we had a lady that turned beet red after had a nickel allergy, and we put a device in her, and she was miserable. We had to remove it, and then she turned normal color again.
So, Henry, if you could just zoom in on our trolley here. So the delivery cable is very much like the Abbott delivery cable, and there's a thread and a screw on the end. It just goes through a kind of usual introducer, really, and the device comes in a pack, and it looks like an implanter, eventually.
Neil, have you got the slim cable or the fat cable? It has two different cables. So have you got? Yeah,
there's a 5 French, and I've been given a.
It looks floppy. Yeah. So I like the floppy one because then it takes the conformability a bit more. The stiff one is a bit like the very, very, very old Amplatzer cable where it takes its own shape until you release it.
Is that what the card is for? So that you can load it without touching it?
So basically that's what they say, and I do what Neil does, is tear it off because I think it gets in the way. I don't know why they've got the bloody card there. Okay. If you can't load a device without a piece of card, you shouldn't be doing interventional cardiology.
No, but it's clever, so you don't have to touch the device.
I mean, that might be the theory.
Why, Dave, do you have a nickel allergy? You don't want to touch the device?
No, I just like not to touch it. It seems like a bad idea. I don't want to get infection on it.
I wear gloves, Dave, so that's probably the tip.
Oh.
And so a bit like an Amplatz, it's about 8 turns, and then we kind of always go back 1 or half a turn just so that we can deploy it in the body.
So Neil, under the hand there, what you're doing is you're stretching the device. I don't know who everyone else stretches the device. So I think if you stretch the device and pull it in, you're less likely to catch the braiding and produce a cobra. And the bigger the device you use, an ASD device and things, I think more important probably is to stretch. Dave, do you stretch?
No.
It's hocus pocus. Oh my God.
I mean, I think we learned that a bit from the early Octatech devices. It seems the Cobra required a lot, and we learned that stretching them out reduced the rate of that. I think obviously now that's less of a problem, but
not sure you can
kind of carried on doing it.
PFO device, can you? Can you really?
Yeah. So what we did was when we were pulling it in without doing that, I always pull it out again, make sure that shape is quite right. I did it. I've got used to it from the very early days when we were using these devices. And if you didn't stretch it and pull it in, every now and again, this device would be in a funny shape, even a PFO device. So that's why it's become routine to pull it in, put it out, makes it looks all right, pull it back in again in the same way, and then deploy it. And maybe it's overkill, I don't know.
Oh, they're about to cross right now.
Yeah, so this is just a sheath going up.
So what I'm very conscious of is how much radiation Bushra gets. And so one thing that we routinely do is if Bushra sees the tram lines of the sheath, which she's going to show in a minute, then you actually don't need to do any fluoro until all the way up and you see the device inside the tram lines. And so it might be worth trying to demonstrate that, because I'm very nervous that if we lose Bushra or Nilesh, our programs are pretty well screwed. So we want to keep them alive as long as possible.
That's very kind. Thank you, Iqbal.
You better check they don't have a PFO then.
So I'm just sort of always meticulous about de-airing, and we had a discussion about the new Octatech sheath with valves and the challenge of doing that. So, I mean, this is a more traditional delivery system that does bleed back, which does give me comfort. And so we can see the tram lines on the TOE, I hope, on your screen. And as Iqbal says, we often just use TOE to advance the device up, and we should see it arrive.
There it is.
What's the size of the sheet for this device?
You're probably using 8 or 9 French, aren't you?
It's a 9.
Yeah, because 9 just gives you a little bit more room to actually just get the device up without pushing too hard.
That's the device on the LA side, which looks relatively coaxial, I think. Wait, I might just need to rotate that.
Is there a particular view that you'll use Bushra for deployment?
Yeah, so I like to see the whole device and the cable, so I know I'm aligned to the central portion of the device, and then that's where then I'll get the best shot of what's going on. So I'm doing it here. I'm looking for the cable, but I think it's lost in the shadowing actually. So we'll see the RA disc. We've come back to the septum.
And
I know other people like other views, but I'm more interested in the whole delivery system and how it's looking.
Grab that, Flora.
Okay,
and we see a pin on the left side then. So there's 2 pins with this device?
Yeah, there's 2 pins on this device, so it's similar to the Amplatz rather than the Octatech device.
So, thanks. I don't. The reason I kind of prefer small discs on the left side, and I don't think it's really an issue here. It's just the touching the aorta business. It's not really been mentioned, but it's not really a huge issue for PFOs. And I think it's probably going to just move off the aorta when you release it anyway. But if you have a big disc, the reason for preferring smaller discs on the left as well as just having less metal on the left is because sometimes they touch the aorta. It's a good example because it's very close, but I don't think it's an issue here.
I mean, to my eye, that looks actually very nice.
So it is just to see, this is the RA view, you're looking at on the 3D. So the disc is sitting here. It is sitting just on the edge of this aorta. I'm going to go and look at it, but I think it's just touching it rather than resting on it. And you can see the ridge coming up. So this disc looks like it's the right size. Any bigger, I think we'd run into trouble. And looking at the other side, The disc looks really nice there, and the point I think that Dave is making about the aorta as well. So it's not protruding onto the aorta, which is here. I just turn the gains up a bit so you can see that better. So which is here. If it was sitting here, then what we worry about is it would then mean that this device is being wedged open at an angle into this region here. So far on 3D, it's actually looking really nice. And I'm just going to do my color compare and just go around. And you can see here, again, the point about the aorta. This is why we wanted a smaller disc as possible. This is the 18 device, and any bigger would have ended up. Sorry, 25. This is 25, is it? Okay, good.
Yeah.
So and it's just about right. Any bigger, we would have run into trouble there. So I'm just going to go around and quickly look at the other views. And again, I'm just trying to show the central pin of the device while I'm imaging, so then I know I'm transecting through the middle of the device, and then I can get a good idea of what's going on here. Septum secundum, you can see it's slightly opening, but I think part of this is because it's angled because it's on the cable, and hopefully that will get better as we release. So I'm looking for color, and again, central portion, then swinging through to look at the septum secundum, primum. So actually, this device is looking very nice.
And I think that's just the point actually with regards to this delivery cable compared to the Abbott and Optitec. It is, even though it's the 5 French, which is less stiff than the 6 French, it isn't as conformal as the newer Abbott or the Optitec that is on the ball. So we have seen that the device does move a little bit more on release than the other 2 devices.
And just on the point about non-self-centering with a PFO type device, obviously the size of the PFO, we've got potentially 7-8 millimeters on one end. It gets to 10 millimeters in the middle on the 3D I'm talking, and then 18. But when we balloon size, the main widest opening was 10. So the fact that we've got a bigger opening on the RA side, it shouldn't be an issue because we've sealed the PFO from the LA side quite clearly.
Well, Neil and Bushra, you made it look really simply and beautiful and easily. We have a request from the audience asking if you guys can lower your color gains to see if there's anything else in the lower velocities.
Okay, we can do if you like. So let's, we're just having a bit of a problem with, you see there's a bit of an artifact on the probe, which is a bit disappointing. But I'm just going to turn the scale down as requested. Well, how low should we go? 30? Happy with 30?
No, that was good. They wanted the gains lower down. They think it's the gains.
No, it's not the gains, I'm afraid. I've just turned the scale down, but sadly it's not the gains, it's the artifact. This is artifact.
It's our probe. I think someone's bitten the probe. Yeah. I've told you, Bushra, don't eat the probe. Have dinner later.
I know, sorry, Iqbal. I must stop doing that.
Well, it definitely looks beautiful. You made it look very easy. Any comments from the panel?
Can I make a comment? Sorry, I was just wondering, just to be difficult.
Good.
So someone mentioned that they were concerned about Bushra's radiation exposure. I mean, like, I don't know why we don't send Bushra back to the echo lab and just do this with fluoro, to be very honest. I see no value in TE here. I'm happy to discuss that with anybody. And the second question is, who cares if the left-sided disc is on the aorta, because the erosion weight for PFO is 0 or negligible, and I don't think it matters at all. So I just, yeah.
To your point, Eric, I just saw a paper coming for your center where you're using pretty much always 35 millimeter device. Would you use a 35 millimeter device in this case?
I think the problem with the 35 millimeter device is it actually, like our general practice had been to use a 35 millimeter device when there's an aneurysm, just to provide better coverage. But I think the problem with the 35 millimeter device is it tends to have more positive bubble studies afterwards. And I think if you use a smaller device, your bubble studies tend to be negative. The whole issue of what the value of a bubble study is another very interesting area. Because, like, you know, trying to quantitate something that's ridiculous doesn't help. I mean, so, you know, there's variable opacification of the right atrium, there's variable Valsalva, and you only are taking a thin cut with an ultrasound beam and not sampling the volume of the left atrium. And so you can drive yourself and the patients fairly crazy with bubble studies, depending on who your echo technologist is who does the echo. So, you know, I think all those points are kind of come up, like, you know, in care of these patients.
Well, love the question because you have set us up perfectly. We couldn't have timed it better to move on to our lectures after this beautiful case by Neil and Bushra. So congratulations, you guys, on excellent skill and teaching all of us about cocoon. Because now we have to go on and ask, why on earth would we need any kind of imaging?
Well done, guys. Well done.
Thank you.
Yeah, actually, I didn't hear about that thing. In this procedure, is general anesthesia or that's just a sedation?
So we use general anesthetic with TOE guidance for almost all of our cases.
Yeah. So I'll make a comment that only a German patient can tolerate a TOE for this long without a general anesthetic. No English patient would tolerate that.
Yeah, because I say in the manipulation, it's most of the very simple and very petty complication is air embolisms under the sedation. So that is one of the very important.
We just want to thank the lab staff, the whole team, amazing. They've come in really early because I know we'll be doing a TAVI later, but we'll be within another place. So just to thank the team who've worked really hard.
Yes, thank you for coming in the weekend too. We really appreciate it. Thank you so much for your